8:30. So let's begin. And thank you all once again for joining, and thank you all for being a patron to this series. It's really meaningful to have an interaction with people who are really interested in this area, and I think that keeps things uh, interesting, and the entire session becomes very meaningful. Okay, so again, those who have joined earlier and those who are new to this, let me just introduce the system. So this is CaReMe Pro 2025, which is kindly sponsored by Zydus Healthcare. The Depaglin is the main center stage here. And we have this is part 3 of the 4-part webinar. So we had the first part, which was there with Dr. Gagan Priya, who is an endocrinologist. So we discussed about a newly diagnosed patient with two newly diagnosed patients with type 2 diabetes and how their journeys panned out. Last time we discussed a case with Dr. Srinivas Kudwa, the cardiologist, about a patient who, young patient who had diabetes and went on to develop myocardial infarction and then heart failure. And today we are going to have our nephrologist, Dr. Arun Kumar, who is going to, enlighten us about a case of a patient who we are going to discuss about a patient who presented with albuminuria with type 2 diabetes. So that's the whole flow. Again, we have put the case in the chat, so you can have a read at the case. It's also there on technochronology.com, so you can go there, log in, sign up. You'll also receive the email if you're registered with this webinar via Zoom, and you can then log into the system and you can access the previous recordings, previous lectures, the previous presentations, and the current ones also. The current one will update in a couple of days as we go along, and there'll be certain poll questions. Again, you will be allowed to put your question in the chat. So you can put your question in the chat box, and we'll be happy to answer them. And in the end, we'll allow some of you to unmute yourself and ask the question to our expert panelist who we have here today. So this is the series we are having. The last one is going to be again very exciting. So we have got Dr. Shafi from Medanta, who is an expert in who's an endocrinologist, but who's an expert in MSLD, and we are going to. It's very exciting to have him for the last part, which is there next week. So I hope you join us for the last part as well. Again, we have this technochronology way. So we have the Shravan, where you learn, imbibe the knowledge, and then you have Manan. So on the technochronology platform, you will have quiz, which you can answer to test your knowledge, and then your Nidhyasan. And we have a little template for you where you can reflect on what you learn, and then you can use that in your clinical practice. So that's the whole pathway journey we are going to. So you can access the course and material. This is the we also put the link in the chat, and you can check it out here through the QR code also. Okay, so without much ado, let's introduce our guest today, Dr. Arun Kumar. So I met him. We had a event on AI recently, and this is the first time I met him. He was again a panelist in one of our AI sessions. I'm very happy to see him. Right, a brilliant speaker and a very intelligent person. And again, I very impressed with his his candor and his way of dealing with during the AI session. So I think we told the Zydus guys here, for our CaReMe session, we got to have Dr. Arun Kumar today. So he has done his MBBS from Rajiv Gandhi Health University, Karnataka, from Bellary, and he has done his MD in General Medicine from Mysore, and he's a DNB from Kerala Institute of Medical Sciences, Trivandrum, in nephrology. He's a renowned senior nephrologist for more than 10 years of experience, and his special expertise lies in ABO incompatible multi-organ transplant. So he's an expert in that. He's a national-wide renowned expert in the ABO incompatible transplants, and he has done multiple transplants of such cases over the years. He's authored more than 40 research publications, and very interestingly, he has a syndrome named after him. So, Dr. Arun Kumar, if you can unmute yourself, what's the syndrome named after you?
So this is actually Lawrence Moon Bardet Biedl syndrome.
Right.
So
Okay.
it is a complex of 5-6 syndromes. So
Right.
I first time found out there is a supernumerary teeth in a family, which was the first of its physical presentation, and we did a genetic test, found out that it is the first of a kind, and then I had proposed that in the paper, and they told that you can have it on your name because it is first
Wow.
reported by you.
Okay. So that's an endocrine case, right? Very interesting. So there's an endocrine syndrome named after you.
Yes.
So I think that's okay. Fantastic. So yeah. So I think so. Thank you for joining today. And
Yes,
this again, our audience is very used to a lighter mood of discussion. So last time, we had a completely. So again, please feel free to put in your thoughts as you feel right. Let's begin the presentation today, the case today, and again, yeah. So there you go. So today we are going to discuss the third part. We are going to discuss about a diabetic patient with albuminuria. Again, if you have your questions, you can put it in the chat, and we'll discuss that as we go along. So it's a very interactive thing. We keep discussing things along the way. Okay. So yeah. Okay. So it's what we call it as albuminuria matters. So we are going to, see diabetic kidney disease from our guest nephrologist perspective, and we are going to see this case, right? Okay. Now, so we are discussing a case of a 59-year-old patient called Mr. Ramesh Gupta, and Mr. Gupta has an electronics shop in Ahmedabad. And again, these are all modeled on real life cases. And one of the themes of CaReMe Pro is to look at the disease from a long journey, right? From a long perspective. So Mr. Ramesh Gupta, age 59, had type 2 diabetes since last 7 years, but has been inconsistent on follow-up, and he's having hypertension. Very interestingly, he has a family history of diabetic kidney disease, and he has a family member on dialysis as well. Again, this makes our patient a little bit more, generally more jittery, sometimes more anxious about the disease. Again, on initial presentation, when he had mainly symptoms of fatigue and had a moderate non-proliferative diabetic retinopathy on examination, and his blood pressure was 148/94. His HbA1c was 9.3. His eGFR was 59. That puts him in a CKD 3A, and he has a urine albumin creatinine ratio of 1,329, which was severely increased, as you can see. And so this was the initial diagnosis that we put: type 2 diabetes with diabetic kidney disease, retinopathy, hypertension, and dyslipidemia. Okay, so we didn't put his lipid profile, but again, let's say his LDL was somewhere around 140s. So this was the thing. Okay, so Dr. Arun Kumar, can you see the screen in the chat, the case on the screen? A couple
yes,
of
sir.
questions.
So,
Yeah, a couple of questions for you right at the beginning.
yes, sir.
So one, we have this dictum that, and this is what we have been taught as endocrinologists, and I'm sure you'll be taught as nephrologists also, that if a patient has diabetes and does not have retinopathy, then probably the kidney disease is not because of diabetes. So how true it is, because this is what we are taught initially when we are students, that a patient with diabetes without retinopathy, so diabetes and diabetic kidney disease without retinopathy, is probably that you should look at some other etiology for the kidney disease. So how true do you think that is?
Sir, actually, that is all as you told, it's a past teaching. So, but
Right,
we have to look at each case in a different perspective. So, if you
right.
actually see diabetics, type 1 diabetes and type 2 diabetes, we split it into that. So,
Hmm.
in type 1 diabetes, the preceding, that is whatever retinopathy, whatever can happen, happens over a period of time because you
Right.
detect diabetes very early.
Hmm.
So, you
Correct.
have a follow-up. Whereas in type 2 diabetes mellitus, the damage is already done when the patient comes to you.
Right.
So, as a classical teaching in nephrology, 60% of patients with diabetes, long-term diabetes, more than 8 to 10 years, will have retinopathy.
Hmm.
And remaining 40, even if they are 20 years on diabetes, still may not have retinopathy. So we need to have that broader spectrum that
Hmm.
not all retinopathies can be because of diabetes, or diabetes only retinopathy patients can have nephropathy. That
Right.
concept is actually wrong. So
That
we need
that's
to
that.
evaluate the patient
Yes.
at his presentation with his symptoms and at his age. So in this case, the age of presentation is 59.
Right.
So
Yes.
5 years preceding that, he would have developed diabetes, thinking that
Right.
it is 5 years preceding, and he has a strong family history,
Hmm.
and is one of the family members is on dialysis. So all this can actually be a contributing factor for him to have nephropathy, in turn retinopathy also.
Right. Okay. Yeah, that's a great point. Dr. Arun Kumar, and we'll discuss, urine albumin creatination in more detail as we go along. But,
Yes, sir.
what can you tell us the difference between, we often see nephrologists asking for urine protein creat
Correct.
ratio and urine
Correct.
albumin creat ratio. So what's the difference between these two, in terms of clinical, when you order
Yes, sir.
these tests?
So, sir, protein creatine ratio is when you have all kinds of protein. That is the
Right.
urinary tube. Generally, the nephrons generally have tam horsefall protein.
Correct.
It also has other proteins which will be in small quantity with albumin. So when you do a protein creatine ratio, you are looking at all the proteins that are getting excreted in the urine, which includes probably a small amount of beta 2 microglobulin. It is tam horsefall protein and any other protein which can be excreted in the form of overflow proteinuria also.
Right.
Whereas when you're looking at albumin creatinine ratio, it specifically looks at albumin. So that is very, very sensitive in picking up early diabetic kidney disease or diseases pertaining to loss of only albumin. And most common disease which causes only albuminuria is diabetes mellitus. So
Right.
most of the times when we look at these two things with respect to the age, if you are doing a screening test and determining early diabetic kidney disease, then it has to be urine albumin creatinine ratio. That
Right.
is very sensitive marker. It will pick up your nephropathy early, and then if you want to follow up, for example, there may be patients with concomitant symptoms of back pain, anemia, aged 65 years, probably having multiple myeloma. In such a scenario, when you do a urine albumin creatinine ratio, you may not pick up the albumin. So at that scenario, you may need to do urine protein creatinine ratio.
Okay. So in short, for a garden variety, of a diabetic patient with a protein, with a CKD, you are probably urine albumin creatinine ratio would be a better test because it's more sensitive and detects the problem disease early, right? So is that what I understand correctly?
Yes, sir.
Yeah.
Albuminuria or urine ACR is very specific for picking up early diabetic nephropathy.
Right. Okay. So let's run a quick poll question for the audience, and while we run the poll, we'll also continue our discussion. What we're doing. So just give me a second to launch the poll. Okay, so this is we already saw the case of Mr. Gupta. So Mr. Gupta here is 59. You saw the clinical profile of the patient. Beyond the so you have so which of the following management strategy would you prioritize beyond the lifestyle measure and metformin? Sorry. So would you focus on solely on glycemic control? Sorry. Would you prioritize the blood pressure control? Adding drugs like CCP and amlodipine, would you initiate a RAS blockade immediately because of his clinical profile, or would you initiate RAS blockade and SGLT2 inhibitor upfront, or would you straight away refer to a nephrologist? So, Dr. Arun Kumar, you saw the patient's profile here.
Yes,
So
sir.
this is a lot of like a blank canvas right now. You have a diabetic patient, probably just on lifestyle measures and metformin, and he's having hypertension, he's having proteinuria, his EGFR is 59. So what is your, maybe top priorities in terms of management of these patients?
Sir, a very, very important here is he has significant urine albumin creatinine ratio. As I
Right.
told you, one, he's a 59-year-old.
Mm.
Second, he has a strong family history of DKD.
Mm.
Three, he has presented with urine ACR, which is very significantly high. So
Right.
what we need to do immediately is to initiate him on anti-proteinuric measures. That includes one, diet modifications. Second, medications. In medications, two important drugs that is very, very essential are using a RAS inhibition and also using upfront SGLT2 in such cases.
Right. So both would be initial priorities, right? So
Yes,
putting the
that would
patient
be the
on
initial priority.
both would be, right? So I think
Yes.
that's what the overwhelming majority of the audience has also said, that you would probably consider both upstream upfront as the priority. You'll have both the RAS blockade as well as the SGLT2 inhibitor use in such cases. Now, Dr. Arun Kumar, we have a question from the audience. So somebody with a EGFR of 59, would an HbA1c be a reliable test for that patient, or would you be a little concerned about the potential use case there?
So generally, EGFR it's very essential for us to do it at the baseline.
Right.
So we get to know what is the kidney renal, that is renal function at the
Right.
outside. So
Right.
primarily when you do a EGFR, you tend to either underestimate or overestimate. When there is hyperfiltration, you are overestimating, and when there is renal dysfunction, you are underestimating it.
Right.
So prioritizing and doing a EGFR at the earliest is very, very essential in a diabetic nephropathy, and earlier the better.
Right. Okay. So the question from the audience is about HbA1c. So I'll just answer that. These days, of course, to the I think it's an anonymous person who has asked. So HbA1c is a reliable marker at this EGFR. The questions of really HbA1c being a problem happens when you have end-stage renal disease. Where you have certain potentiality of certain interactions which can lead to a misclassification of HbA1c. So I think at this stage, of course, it should not be much of a problem. Okay. Right. So I think there are certain other questions which we'll take later on, and then let's move on to the the next point. Dr. Arun Kumar, you talked about EGFR. So what formula do you use, as a nephrologist for calculation of EGFR in such patients? What's an ideal formula to be using?
So generally, previously we were using Cockcroft Gold.
Right.
Then there was an advancement in Cockcroft Gold because there are a lot of parameters which were not appropriate. So we went into MDRD after the MDRD study. But
Right.
later on, now we use CKD EPI. CKD EPI is an ideal EGFR calculator, which will exactly tell you the EGFR. So now we use, generally all the nephrologists use CKD EPI.
Right. Okay. So CKD EPI is the ideal test to do. And we all heard about Dr. Arun Kumar. This was a question which was asked in the last webinar also by somebody. We are all about cystatin C. So
Yes.
where do you really use cystatin C, and what's the importance of cystatin C while evaluating such a patient?
So generally, cystatin C is a more specific marker for early kidney injury. So
Right.
it initially was determined as a marker for GFR. That is predominantly, it is very sensitive for determining any decrease in the GFR. So because it is not secreted, it is only filtered. So it exactly mimics the GFR. So cystatin is a very promising marker for detecting EGFR, means GFR. So predominantly we use it in acute kidney injury. We use it in a condition where we need a very specific understanding whether there is worsening of renal function or not, because there is a lag in creatinine. Whenever you do a creatinine, there is a lag of 24 to 36 hours with respect to increase in creatinine or decrease in creatinine. So in such a scenario, we use cystatin C. So we have specific markers now using cystatin C as a EGFR marker, like how we use creatinine, and we use the CKD EPI EGFR calculator. We have a cystatin C calculator also. So cystatin C is used in sensitive conditions, predominantly when you want to know whether there is an acute kidney injury and whether there is recovery from an acute kidney injury, and in conditions where creatinine is not a very good marker, like when a patient is very cachexic, so there is not much muscle in his body, so that the creatinine generation is very poor. So in such a scenario, we can use cystatin C, and sometimes we do use it in transplant scenario where you want to know whether there is damage in the kidney or not. So these are the altogether scenarios where we use cystatin C as marker.
Right. Great point. So basically what you're saying is that when it's an early marker of diabetic of kidney injury, so and creatinine lags a little bit. So again, when you're thinking of an acute condition, probably cystatin C would be a better test. I think from the second point which you said, I think somebody who is cachexic, somebody who who has muscle loss, maybe muscle injury, such cases again, creatinine may be sometimes false, the mark. So I think that in that case, cystatin C would be a better marker. So at this point, this is what the patient was. And as we went along the journey, so this is what actually happened to this patient, right? And sometimes, we see a lot of times, patients not being kind of on the right track. So this patient, when he first came to the, to his doctor, he was just on metformin, but he had microalbuminuria there. And, you already had EGFR of 59. He was, again, he had a family history of diabetic kidney disease, already having a retinopathy. Yet he was started on a metformin, glimepiride, amlodipine, and atorvastatin. Now, there was notable omission of RAS inhibitor at this point of time. And again, that was not, and the SGLT2 inhibitor, which should have been given, was not given. And this patient, again, through his ages of 59 to 63, actually had a progression of his diabetic kidney disease, because probably that intervention, which should have been ideal for him, was not done. And then, as he went along, his HbA1c increased to 8%. He continued to have a little bit of hypoglycemia with glimepiride, so he had poor adherence to glimepiride. He had a little bit of pedal edema with amlodipine, so he stopped amlodipine also. So he basically, had these issues, and because of that, some of the medications he omitted on his own, and he stopped glimepiride and amlodipine. Started himself on some Ayurvedic remedies, and then ultimately had an infrequent follow-up. So this was a stormy period for this patient where he actually did not, neither was he put on the right course, by the doctor at that point, unfortunately, and nor did he really comply with his medications at this point of time. So, Dr. Arun Kumar, let's talk about the choice of antihypertensives, right? And we all know now that putting such patients on ACE and ARBs are very important compared to putting them on amlodipine. Yet something like an amlodipine or even beta blockers continue to be very popular amongst primary care physicians in practice, whereas ACE inhibitors, ARBs are still, that knowledge is not there. So again, from a nephrologist perspective, how important is it to put such patients on an ACE or ARB?
So primarily, whenever you're looking at diabetic nephropathy, sir, the predominant damage is to the raise in the intraglomerular pressure. So what you look at is try to reduce the intraglomerular pressure. So RAS inhibition actually reduces intraglomerular pressure. So very important in a condition where a 59-year-old with proteinuria who's come with hypertension also in the end, and hypertension can worsen the proteinuria. So in such a scenario, when you use a calcium channel blocker or a beta blocker, we can reduce the blood pressure, but we cannot effectively reduce the intraglomerular pressure. So once you reduce the intraglomerular pressure only, we will be able to reverse the diabetic changes at the early stage. So RAS inhibition and the newer drugs, SGLT2 inhibitors, and also the MRAs, the newer MRAs, all of them have a positive feedback on the tubuloglomerular feedback effect, in turn reducing the intraglomerular pressure. So when the afferent arterial pressure reduces, automatically the intraglomerular pressure reduces. That is why we choose RAS inhibitors, MRAs, or SGLTs as primary or the first line of medications in a patient with proteinuria or albuminuria in diabetic nephropathy.
Great. So great point. So basically, it's not just essential to reduce the systemic hypertension, but it's also very important to reduce the intraglomerular blood pressure, which is the intraglomerular pressure, which is, I think, that has direct correlation with the hyperfiltration and direct correlation with further renal damage, which is a common problem. I just take one question from the audience, and which is dealing with the urine albumin creat ratio again. Once we go ahead. Dr. Arun, how do you classify, based on the severity of albuminuria, based on the levels that you see, and what is the importance of these classifications?
So previously, we used to have a classification called microalbuminuria, macroalbuminuria.
Correct.
That classification has now been changed to moderate, severe, and early. So early damage, moderate, and severe albuminuria. So these previously it was micro, macro, only two classifications were possible. Here we are able to grade in further detail whether it is severe, that is A1, A2, A3, and then moderate, and then mild. So in the mild form, you have subnephrotic or microalbuminuria status, whereas if it is macro, that is a little more, then you call it as moderate albuminuria. Severe is when you have proteinuria more than 2.5 grams. And generally, we call 3 and 3, above 3 as nephrotic syndrome. But here, anything below this nephrotic syndrome is called moderate. So the classification is now from micro to macro is changed to mild, moderate, and severe.
Right. Which is a great point. So I think that is something which you all need to understand, that, the terminologies have now changed. We no more use micro and macro, rather we use the staging, which says that, there is a tendency towards, classifying them in a more graded manner. So again, Dr. Anand has asked here, Dr. Arun, that is there a particular microalbumin level, USER level where you would like to, or urine albumin creatinine ratio level where you would like to consider SGLT2 in preference to other antidiabetics?
There is no specific level, sir.
Right.
The earlier the better. So SGLT2, as I told you, earlier the better. If it is less than 30, so less than 30 is considered as normal. And if he is a diabetic with less than 30 milligram of albumin with 5 years of diabetes, still it is better to start SGLT2. And if it is more also, it is better to start SGLT2 at the earliest, because we are not only looking at treating that albuminuria, but stopping the albuminuria to occur in the future.
Correct. Very true. Very true. So I think, Dr. Anand, I think if that answers your question, the answer is there is no level, right? So I think the renal protection point of view, SGLT2 again carries a center stage in terms of management. So again, if you have a patient where you want to achieve renal protection, then you should consider using this. Okay, so we run this poll question here quickly and take everybody's opinion. Okay, and then we'll discuss some of these points with Dr. Arun also. So this is the second poll question. So Mr. Gupta experienced hypoglycemia with glimepiride, leading to non-adherence. In such a scenario, with baseline HbA1c of 8 to 9%, with the CKD6, G3A, G3B, which alternative glucose-lowering agent would you prefer after metformin? So I think again, this is a needless to say. I think we already answered this by Dr. Arun. But Dr. Arun, now there's a lot of emerging evidence with GLP-1RA also. So let me play the devil's advocate. Where do you put, again, from a nephrology perspective, where do you put GLP-1RA in today's era, where you want to, again, achieve renal protection, beyond the usual treatment that we have?
So GLP-1RAs are also a promising drug as of now, the newer varieties. But the thing is, I think there is a little cost factor involved in that.
Right.
So there is a lot of cost benefit with respect to SGLT2s and your drugs which you are using at present. So only the cost factor, but GLP-1RAs also score as equally as SGLT2s, but a lot of studies still needed for us to get the complete picture, like how we have got SGLT2 benefit both in cardiorenal. The same benefit is also there in GLP-1RAs, but the cost factor is, I think, the only limitation for us to go ahead and prescribe.
Yeah. Yeah, I think, it's a great point. So cost is a very important thing, which makes SGLT2 better. Again, most SGLT2s are, of course, all SGLT2s are oral, whereas most of the GLPs are injectable. That also becomes a little bit of a challenge for certain patients. So I think, it's a no-brainer. I think SGLT2 gets a preference on GLP because of both the cost as well as the, ease of use, especially in current era in India, where, this is much cheaper. Again, if you see the recent studies, now you're looking at some of the studies like the SOUL trial, where they used an oral semaglutide, but a lot of the patients were already on SGLT2. So the benefits that you got were beyond, of course, there were certain benefits beyond, use of SGLT2 also, but the patients were already on, there are a lot of patients already on SGLT2, which makes that, the treatment is now changing. And, even the West, or even in clinical trials, there are a lot of patients who are already on SGLT2 when they begin. So Dr. Ravi has asked a very interesting question, which, I'd like to pass on to you, Dr. Arun. What's the ideal way of taking a spot sample for urine albumin creatinine ratio? Should you do an early morning sample? How many tests would you repeat? What's your protocol? What's an ideal protocol?
Yes, sir. Ideally, sir, it should be done at the second urinary sample of the day. For example, whenever you overnight, when you sleep, so generally there is a tendency for them to give a random urine albumin sample, which is not advised. So it should be given the second sample, because the whole night the urine will be in the bladder, and if you give the first sample, your albumin ratio is going to be very high. So because there is a lot of breakdown happening at the 6 hours time when you're not passing urine. So ideal would be to hydrate appropriately, not to drink any drinks like aerated drinks or coffee, tea. And you can just drink water and give second urinary sample. And midstream sample is very, very essential, because early sample can be contaminated. So it is always better to give second urinary sample and a midstream urine for urine ACR or PCR.
Okay. So I think great point, and I think that should answer Dr. V's question very well. So let's move on with this case now. Mr. Gupta, he has now has been referred to a nephrologist when he came at the age of 63. Remember, he was not compliant with his treatment. He was taking some Ayurvedic medication. I mean, nothing wrong with that. The idea is that he was not, compliant. Basically, the idea is there was worsening of edema. He was having lethargy. And at 63, when he first came back to his nephrologist, here the name of nephrologist Anjali Desai, he went to her. At that point of time, his creatinine was 2.1, his EGFR had dropped to 35, his HbA1c was 8.8, and you can also see, he has persistently severe A3 grade of urine albumin creatinine ratio. His blood pressure is 150/95. Okay, so Dr. Arun Kumar, would you at this point of time, now you have this patient with you, what all treatment you'll offer? So this is your patient, let's say, this has of course been referred to, Dr. Anjali Desai. Let's say you are treating this patient. You have this picture with you. You have his history now. What would you, give in terms of treatment? Again, let's keep cost aside. Let's say the patient can afford whatever we prescribe him. What would be your ideal playbook for this patient?
So primarily, sir, he's having a renal dysfunction and a rapid decline of GFR with a higher HbA1c and persistent proteinuria, which is almost in the severe grade with hypertension. So for all this, there should be one drug which probably acts onto all the mechanisms. And in such a scenario with the age of 63 and probably a worsening of renal function, he would have a cardiac abnormalities also. So keeping all that in mind, so I think we should, before he was not started on SGLT2 and he was not on SGLT2 before. So we have to start him on SGLT2 at this point of time because he has a rapid decline of GFR and also has other things which needs to be tackled at the earliest. So irrespective of the creatinine, I would like to start him on SGLT2 inhibitor and then see how it goes in the next follow-up.
Right. So I think, this also correlates with the question which Sanjeev has asked. Dr. Sanjeev has asked that, at what EGFR would you consider starting an SGLT2 inhibitor? And do you see that initial drop in EGFR which happens when you start a patient on SGLT2?
Yes, sir. Generally, whenever you start an SGLT2 inhibitor, there is a 1 to 3 ml GFR fall, which happens because there is suppression or rather afferent arteriolar constriction, so reducing the GFR. So in the long run, the same mechanism will reduce the intraglomerular pressure. But the initial times when you start on SGLT2, there is a decline in EGFR generally.
Yes. And
it's very minimal.
Yes. So what EGFR cutoff do you currently recommend for starting SGLT2?
So generally, if you go by the data, generally there are two things. One, the data that is available and the clinical experience that we have. So data says that any GFR which is less than 30, you're not supposed to start SGLT2 inhibitors. But it's not that. We can start if you have already started, you continue is what they say. But if the EGFR is, it's going to benefit the patient and you can keep a close watch on him, he's not going to be lost on follow-up, then you can start him on EGFR even below 30. I would prefer to give the benefit to the patient clinically, not theoretically. Clinically, will give the patient SGLT2 inhibitors, even if his EGFR is less than 35. So for me, there is no cutoff. I will only see at the benefit and his profile. Whereas if you go into data, you're not supposed to start a new SGLT2 inhibitor if the EGFR is less than 30.
Yeah. So I think they've brought that down now to 20. So you can actually start up to 20. Again, but you are very right. You look at the patient as a whole, the risk versus benefit. And again, patients continue to benefit even with a lower EGFR also. And I think Dr. Sanjeev has also asked about metformin. So let me just clarify, EGFR of less than 30, you generally don't initiate metformin. 30 to 45, you can give up to 1 gram, and more than 45, you can give the full dose of metformin. But having said that, again, even with metformin also, now things are changing, and now a lot of new data has shown that it's a pretty safe drug even at lower EGFRs. The only thing is that at a lower EGFR you have a slightly higher theoretical risk of developing lactic acidosis, which is a very, very rare entity with metformin. So that is something which metformin does face in terms of the challenges. Okay, so Dr. Arun Kumar, this is one question which is a persistent clinical issue. Dr. Venkatesh has asked this, and I think he asked last time also, in the talk. I think we said we promised him that we'll have the nephrologist answer this. One of the major challenges with prescribing an SGLT2 is urinary tract infection. So, how do you deal with that? I mean, you have that theoretical risk of UTI and GTIs, Genital urinary tract infection, again, very common in Indian patients. So how do you, what do you do, and when do you, where do you draw the line in terms of the UTI risk?
Primarily, when you have an elderly gentleman, we need to thoroughly assess if they have undergone a previous urological procedure, because
Hmm.
there is intervention, recurrent UTIs in the past, and what is the present status with respect to the urine routine. So
Hmm.
generally, the elderly age patients, we generally tend to have benign prostatic hypertrophy. So they would have a subclinical kind of infection going on. So when you
Hmm.
start a SGLT2 inhibitor, they have a tendency to have urinary tract infections or genitourinary tract infections. So primarily what we should do is clinically first check urine routine. And if he has had past urinary tract infections, be very careful to start and continue. When you're continuing, be very judicious in testing his urine culture or doing a urine routine and seeing if there are pus cells which is worsened than last time, and also see if he has had past history of renal calculus, any stone. All such
Hmm.
things can worsen when you're starting SGLT2 inhibitors. So for
Right.
that, first history, second, do a urine routine, three, do a baseline culture before starting, and then you can go ahead and start SGLT2 inhibitors and tell them clinically if you develop lower abdominal pain, dysuria, or if you're feeling burning sensation while passing urine, immediately report to me, and then we check the urine routine culture, and if it is positive, then treat and stop the SGLT2 inhibitors at the earliest. So only the high risk population and people who can have urinary tract infection in a recurrent form, such patients have to be kept in the radar and they should be followed up very regularly. But it
Right.
is a reality that there is chance of urinary tract infection, more so in patients who have undergone interventions, urinary interventions,
Hmm. Hmm. Hmm.
surgeries, and then recurrent UTI patients.
No, it's a great practical point you said. I think, again, to Dr. Venkatesh, I think, this is a great take home message. What I'll say is, like you very rightly said, if you have a patient with a complicated history in terms of, urological issues, maybe, you wait and watch, maybe think twice. But the other patients, who do not have such history, again, you look at the risk versus benefit. And clearly, in patients like this, the benefit far outweighs the risk which is there. Again, genital urinary tract infection is very common, but especially in non-circumcised males. So what we generally advise to these patients is that they need to after passing every time they pass urine, they just need to have their foreskin out and clean that part with water, with gentle water, with just normal water, and that often prevents the patient from developing genital tract infection, GTIs. And a lot of the times, if the patient already has GTI, at that point of time, we don't initiate SGLT2, but once that is cleared, you can consider again restarting SGLT2 also, because the benefit far outweighs the risk which you have with genital infection. So that's one of the important thing, that the benefits, again, in terms of both cardiac as well as the renal benefits, far outweigh the minor risk that we have with the genital infection. Dr. Arun Kumar, now we have the major pillars in terms of CKD progression. You have the MRAs and the Finrenon, and the SGLT2 and the ACE ARBs. So when a patient like this comes, when you start everything, all of them have been known to worsen the EGFR, right? Transiently, when they started. So would you start them all together, or would you start them step by step?
So generally, the all of them can cause hyperkalemia. That is the first
Another
point.
problem, yeah.
Second of them, when you start RAS, there can be
Hmm.
reduction in GFR. Even in SGLT2, there can be reduction, and in Finran also there can be reduction. So the creatinine may slightly go up when you start at baseline. So
Hmm.
these two problems. With that, SGLT2 can cause urinary tract infections.
Hmm.
So in a population, when you are starting, start two things add together, and then you can add on the other. Like for example, if you
Right.
start a RAS inhibition, you can
Hmm.
add SGLT2, and then
Hmm.
slowly, if both of them have shown good benefit and you want to add the third drug, make sure that the potassium is fine when you're starting the finerenone. So
Hmm.
potassium is very important when you're looking at finerenone, whereas you have to look at urinary tract infection in starting an SGLT2, and RAS you have to see the creatinine. So these three have three different mechanisms that you have to look into. So creatine will look into the GFR, SGLT2 will look into the urinary tract infection, and finerenone for hyperkalemia. So always better to start two together and add on the third is what is my practice that I have had, sir. But I have seen doctors, seniors who start all the three together and also keep a close monitoring on all of them. So, but eventually, in I think 2 to 3 years, all of this will become the first line drugs for every problem in diabetes. That is what I personally feel also.
No, I completely agree. So I think it's a great, again, great practical point. Start with two, and then you can add on the second and third, the third and fourth, as we go along. And Jan has asked this very interesting question. So let's say your patient is on a diuretic and you're adding an SGLT2. Let's say patient has heart failure and already on a diuretic. Would you adjust the dose of your diuretic? Would you reduce the dose of diuretic when you're giving an SGLT2?
So primarily, we need to see what kind of a diuretic we are adding. If you're adding a loop diuretic, then if the patient, we need to see whether the heart failure is producing a lot of fluid overload. If there is a fluid overload, then ideal drug is a loop diuretic. If he doesn't have a significant fluid overload and he is on chlorthalidone or thiazide kind of diuretic, then we need to alter the dose as per that. Whereas when you're adding SGLT2 and a loop diuretic, in a condition of heart failure, you don't need to reduce the dose of diuretic is what I feel. Why it is added is to reduce the overload status. So we need more diuresis, actually speaking. So at that scenario, we don't need to reduce the diuretic dose, but it purely will depend on the patient's scenario where if he is overloaded. Ideal way to monitor that, whether it is adequate or not, is doing daily weight monitoring. So if your adequate dose of diuretic with SGLT2, both of it can cause diuresis, and he is reducing 1 to 1.1 kilo in a day, that is acceptable. So weight monitoring and diuretic with SGLT2 can be monitored with weight gain, just by weight gain and weight reduction.
Okay, that's a great answer to this. Again, so let's see this patient's journey further, right? So this patient came at 63 now. He was started on telmisartan, ARB, a maximum dose of 80 milligram was achieved. I think amlodipine he was already on, which was restarted again. Metformin was continued, and his atorvastatin was increased to reduce the cardiovascular risk. He was started on a dapagliflozin 10 milligram once a day. As we had expected in this patient. So, Dr. Arun Kumar, a couple of questions again on antihypertensives. We all been told and taught from the pharma sector is that cilnidipine has a little bit of benefit over proteinuria reduction compared to amlodipine. Is that true? Do you see that in clinical practice? Do you see a difference in CCBs in terms of their use?
Sir, to be very frank, I don't see much change with respect to cilnidipine and amlodipine, but amlodipine is a very good antihypertensive, whereas cilnidipine is a rather moderate kind of antihypertensive. So both of them actually score more, but whereas amlodipine has in the long run has that edema concept. Other than that, proteinuria, I don't think it is very significant. It reduces proteinuria.
Right. Okay, so that's a great point. So again, you continue to use it as antihypertensive from the systemic hypertension perspective, but from intraglomerular blood pressure, you very rightly said an ACE inhibitor, ARB, or those class of drugs, the RAS blockers should be used at some point of time. And what's your choice of ARB or ACE inhibitor?
So generally, I use telmisartan.
Right. Okay.
Yeah. Or olmesartan, any one of them, but predominantly it is telmisartan.
And ACE inhibitor or ARB, what's your choice? I mean,
sir, start with ARBs.
Right.
Generally, start with ARBs usually.
Okay. Great. Okay, so let's take the next poll question for the audience and second. Okay, so Dr. Desai, in this case, started the patient on dapagliflozin with eGFR of 35 according to the current guidelines in initiating SGLT2, which is appropriate. What's the appropriate level? So I think this I think we already discussed this, but you can actually start. I'll just answer this. The new guidelines are very clear that you can start. This is what Jan also had asked in the chat. I'll just quickly answer that. Up 2025 eGFR also you can start. The guidelines are that you can initiate at that level. So more than 20 eGFR you can initiate. But the only catch is that, there could be a transient worsening. Second, very important thing we have to all remember is that as an anti-diabetic, it is not very effective at lower eGFRs, but as a agent which protects the kidney, it is very effective. So it continues to have its benefit despite having low eGFR. And another important point I'll tell you is that, again, the guidelines are clear. So the KDIGO guidelines are now very clear in saying that if the patient's eGFR drops while he's on SGLT2, you continue the SGLT2, right? So That's I think sometimes, Dr. Arun, we see patients triggering into acute tubular necrosis, certain times. What kind of patients develop this with, where you'd be very cautious in giving SGLT2?
So generally, in patients who are already on alternative medications, very commonly they can develop acute tubular interstitial nephritis, or patients who are on NSAIDs. So if
Right,
they take
right.
multiple doses of NSAIDs, and in patients who are taking these native medications, so which is prepared in the village atmosphere, such patients, and patients who have hypersensitivity to these penicillin group of drugs. So antibiotics, when they take antibiotics and with that SGLT2, it can worsen your interstitial nephritis, and it can cause ATN. So predominantly in such a scenario, it causes ATN.
Right. So certain patients, again, you have to be very careful. Again, a lot of the time it is because of maybe some other agent added on, and then that kind of creates a problem. Even sometimes very grossly dehydrated patient, or, such cases also, you have to be very careful. Otherwise, again, a patient like this who walks into OPD probably should not be much of a problem. And Dr. Ravi has asked this very interesting question. As far as the ARB is concerned, and you talked about telmisartan being your choice, is there a creatinine cutoff or a EGFR cutoff where you say that, probably I'm a little, skeptical about giving a ARB?
So the same way as you told, now they have brought down the GFR for using the SGLT2s. We have
Right.
actually gone higher on the level of using higher doses of telmisartan when the
Right.
EGFRs are lower.
Right.
Because what has happened is, whenever you initiate a ARB, you have a baseline creatinine, and if the creatinine goes up by 30% of the baseline, so you tend to be very careful of continuing the dose with ARBs. First week you start on ARB. If the creatinine was 1.3 and it goes up to 1.8, then automatically you have to reduce the dose of the ARB. That is the teaching guideline. If the hike in the creatinine is less than 30% of the baseline, then you don't need to change the dose. You can go full dose. You continue that for 2 weeks. Repeat the creatinine. If the creatinine is not gone up, then you go on escalating till he tolerates the dose. You can even go up ACE with the 200 mg of Ramipral. I have seen patients who are on 200 mg of Ramipral, and also 360 mg of telmisartan. So
Wow.
it is very important and we have our Dr. Mani sir, who is from Chennai. So he always tells, fill the patient with ARBs because intraglomerular pressure reduces. So he gets more life when you fill him with ARBs. So the classical teaching is, when the creatinine goes up by 30%, you need to alter the dose. If it is beyond 30% at the first dose itself, don't give the ARBs, stop the ARBs, give 2 weeks time, find if there is any other cause like dehydration, fever, urinary tract infection, treat them and then restart. But what they say is, give multiple chances of ARBs to the patient. Don't deny that to them just because the creatinine has gone up by a little.
Wow. That's a great point. So, 320 milligram of telmisartan, right? So
Yes, sir.
that's amazing, So I think, so I think it's it's the essential drug, life-saving drug at this point of time, and it should not be denied to the patient, very rightly said. So this patient, Dr. Arun, he was started on DEPA, he was tolerating it well. There was an initial dip in EGFR as we had expected from 35 to 32, which is fine. And then his blood pressure also came down with the ARB which we'd added. His HbA1c improved, and his urine albumin creatinine ratio also reduced. And there was again a little bit of improvement in terms of symptoms, the fatigue, edema, etc. Also improved. So Dr. Jan had asked this question, and let me repeat this to you. We have all heard that there is an improvement in the hemoglobin levels in patients on SGLT2 with CKD. What's the truth to that, and what's the mechanism? Do we know anything about that?
So, sir, SGLT2s generally have a strong effect. See, the interstitial cells are the cells which produce the erythropoietin. So, generally, there is an interstitial damage which happens in diabetes. So, it happens this way. The mechanism is, predominantly there is intraglomerular pressure increase, mesangial hypercellularity. That in turn is transferred in the pressure in the form of damage to the interstitium. So there is interstitial fibrosis and damage to the interstitial cells. Whereas when you give an SGLT2 inhibitor, it will reduce the intraglomerular pressure. That in turn will reduce the remodeling. It will also stimulate the tubuloglomerular feedback effect. in turn reduces the damage and the mesangial proliferation, in turn reducing the damage to the tubulointerstitial space. So in
Right.
that way, when you look at it, overall SGLT2s will probably preserve the interstitial cells, and it will also help in physiological synthesis of erythropoietin, that in turn will increase your hemoglobin. So predominantly in CKD, you have the suppression of this erythropoietin. That is why you develop anemia. So that is probably one of the possible mechanisms for SGLT2 inhibitors having a positive feedback on the hemoglobin.
Okay. So it's an excellent, suggestion. And Dr. Arun, how frequently do you check the urine albumin creatinine ratio on follow-up? And what kind of, typical patterns that you see? Is there a dip like this early on, or is it it takes time, lags for it to fall? How do you see?
So generally, when you start RAS and when you start SGLT2 inhibitors together, RAS has a very strong and a positive effect immediately, whereas SGLT2 takes some time because it has a mechanism of whole remodeling to change. So initial dip in the EGFR, and later on it will pick up. The EGFR will come back and there is alteration in the remodeling effect. When you immediately start on these two medications, generally you see immediate downfall into the proteinuria. So proteinuria improves immediately because the most important mechanism is the raise in the intraglomerular pressure for the proteinuria to
Right.
happen. So that is tackled. So initially you will find a good fall. Then later on it will take time for it to fall further and come back to normal. So generally what we look at is at least a 50% fall in the first 4 to 8 weeks from the baseline proteinuria. So not everyone will come back to 0.5, but 50% reduction from the baseline is a very good fall. If they are falling by 25%, then you need to see that alteration in the dose or requirement in it, escalating the dose of RAS and SGLT2s if needed, or adding a third agent. If the 6 to 8 weeks, if they are not showing any improvement, then probably you need to think of adding a third agent. But generally, early in the start of SGLT2 and a RAS, you have an improvement in proteinuria significantly.
Okay, so 50% drop in about 6 to 8 weeks, right? That's what you will target,
Yes,
am I correct? Yeah. Okay. It's a
Yes,
great learning point. Great learning point. I think it's, thank you for that. So let's say there is no drop here. Would you consider Finrenone as the third agent which you'll add? What would be your
Yes, sir.
choice?
So once, because Finrenone also has effect on the remodeling, it also has effects on your proximal tubule and also the distal tubule. So all the mechanisms will be covered. One, the renin will be covered by RAS. The SGLT2s will cover the other angiotensin and other mechanisms, whereas the MRAs will be covered by the MRAs. So adding a third agent when there is no significant reduction will add on to the and strengthen our armamentarium. It's like using a spice missile and hitting the target.
Right. Great. Okay. Wonderful analogy. I think, Dr. Arun, when we see this patient's journey further, so he was from 6 months to 2 years, he was on a metformin, telmisartan, amlodipine, and dapagliflozin. Any role of 5 milligram of dapagliflozin? I think a couple of audience questions have been there regarding 5 milligram. So the lower dose, especially from a renal perspective, would you give a lower dose to any patients, especially when your EGFR, which is, slightly lower?
So I think you can use a full dose when the EGFR is 20, then why to use less dose?
Correct.
It's my personal opinion.
No, I completely agree. I think, because even the, clinical studies are done with the full dose now, 10 milligrams. So I think that again is so great point. So why give smaller dose when you have the full dose available, right? Which is safe. Okay, so this patient was there from 6 months to 2 years on regular follow-up. You can clearly see his EGFR decline had slowed down, right? And this is where, giving another analogy with Air Force, what I'll say is that, this is one of the common thing I tell my patients, that what is happening is basically it's like, EGFR is falling, right? So it's like falling without a parachute. But if you are using these agents, it slows down the fall, right? It breaks your fall, so your fall becomes slower. You're still falling, but the fall is much slower. And, probably, it will kind of, maybe you'll never fall, you'll float all the time, right? That's the hope. So that's the whole idea. But, there is a decline of EGFR, which you'll see, but it slows down the decline of EGFR. Am I correct in my assessment, Dr. Arun?
Absolutely right, sir. Absolutely right.
Okay. Right. So this patient, the urine albumin creatinine ratio also you can see, as Dr. Arun had rightly predicted, went from 450 to 310. There was 70% reduction over a period of time, over a period of 2 years. And then in the EGFR, the HbA1c continued to improve, the blood pressure continued to improve. What would be your target blood pressure in such patients? What levels would you try to keep?
So ideally will be less than 130 to 80, but we do have patients who do well with BP of nearly to 140 to 80, 85. But
Right.
ideally will be targeting to 130 by 80, which is not always possible.
Right. Okay. So that would be your target, right? And again, if you see this patient beyond 2 years, the EGFR had fallen, the had stabilized to 30 to 32 with a urine albumin with 300, 400 and no heart failure hospitalization. So I think this is the outcome in a summarized way from 59 to 63 to 65. And you can see over a period of 6 years, he's doing reasonably well. Okay. Quickly, we are already, running short of time. So I'll skip a few audience poll questions. So let's then we'll take some of the questions from the audience and then we'll move to our concluding remark here. Dr. Arun, anything would you like to add? So you saw this patient's journey over 6 years. Initially he had some stormy period and then there's a period of time where he was lost to follow-up and then came back and then, the right treatment was offered to him and then went on to develop a stabilization over a period of time. Now, the story is still, of course, the patient is still around, let's say this at this point of time, if the patient comes, at the third, point where we saw this patient, that is when at age of 65, when he's, having a slow decline in the EGFR, but his urine albumin creatinine ratio is around 300. It's stabilized, it's not increased, but it's stuck around this point. Would you want to further reduce it with addition of additional missiles like Finderon?
Yes, sir. Ideally, we would want it to go to normal if it is possible for us to reduce. So what we will do is we'll add the third big missile which is there with us and add an MRA. That would be the ideal way to go forward.
Okay, great. So I think these are all great points. So let's take a couple of questions from the audience. Anything you'd like to add before we take the audience questions here?
Not at all, sir. I think we've covered most of the things.
Yes. So Dr. Rajesh has asked, when you first check for the potassium when you start the patient on ACE/ARBs or now of course Finderon, what would the point of time where you typically check for the potassium?
So just before starting, you see whether it is less than 4.5, 4.5 to 5, 5.3, more than 5.5. So if it is anything below 4.5, easily start full dose of MRA and RAS. If it is between 4.5 to 5.5, you start tailored dose. Make sure that you recheck after 1 week after starting off an MRA or an ACE/ARB. And then if it is more than 5.5, be careful to start an MRA at full dose. Don't start it at all. So start at a low dose. And ACE/ARBs, you don't ideally start. And with that, tell them that low potassium diet and reduce excessive intake of potassium in any form. That is, be diet or added form. So usually you have to keep these cutoffs.
Yeah. So I think, another practical hack, again, we learn from nephrologists also, is that, some of these patients are on this low sodium salts, which have potassium, right? So then again, can be a little bit of a challenge, because we need to check what they're having other than the routine stuff. And Sanjeev has asked, does SGLT2 reduce uric acid? Answer is yes. Yes. And Piyush has asked, well, quickly taking the question. So, since we're almost short of time now. He has asked, Piyush has asked about efnodipin. Any quick word on efnodipin? It has been
yes,
shown
sir. Many of them are using efnodipin now in place of cilnidipin. They say it is more effective and it is safe and it is very good for proteinuria. And dose is also very easy to maintain, is what they say. But practical evidence is yet to be out.
Right.
But personal experiences you can use.
Yes. And Dr. Anand has asked that there are certain subsets of patients who don't have albuminuria, right? Diabetic, kidney disease with diabetes and don't have albuminuria. So which are the cases where is that still related to diabetes and B, which are the situations where you look for non-diabetic cause of kidney disease in a diabetic patient?
So generally, if there is no retinopathy, as we started in the beginning, if the symptoms don't correlate with respect to what is he presenting with, and there is no correlation with the laboratory evidences, you have other features which are very significant. That is urinary sediment, which is active urinary sediments. That is severe macroscopic hematuria. And if there is worsening, rapid decline in the GFR, associated symptoms in the form of anemia, severe anemia, which is not in favor of what the patient has. So all these situations, and the kidney is shrunken. If the kidney is normal size, good looking, and the same mildly echogenic, you don't need to worry about it. It could be a diabetic nephropathy. But if it is shrunken or if it is bigger, in both the scenarios, you would like to evaluate for other causes, which are called as non-diabetic kidney disease. And then we do urine protein creatinine ratio in place of urine ACR. We'll do a ESR, calcium, and other associated tests so that we find out. Ruling out myeloma is very essential in elderly patients, and paraproteinemias and many other diagnoses are possible for them.
Right. Okay, great quick summary. Dr. Vinod Abhichandani, who has been a long-term friend, is shared a very excellent article, which I think, all the audience can benefit. New insights in treating DKD from BMC nephrology. He shared the link, and he's had some kind words also to say for the same. So thank you, Dr. Abhichandani, sir, for that kind words. And Ravi has asked, patient having albuminuria or increased risk of cardiovascular disease, would aspirin be justified we know that aspirin now is becoming less of a favored agent for primary prevention, but for a patient with diabetes and urine albumin creatinine ratio that is increased already at a high CV risk, would aspirin be justified?
Yes, better to start on aspirin because it will give some benefit for the cardiological side.
Yes.
So better to start statins and aspirin in such patients when they're having a proteinuria.
Right. So I think we have discussed mostly everything. Just one question at last, we'll take that as the last question. Diet. So what kind of dietary advice would you generally give for such patients?
So generally, proteinuria is usually increased when you take excessive of water, because you take excessive water, it will filter and increase the GFR, which will cause overflow proteinuria. Excessive intake of salt, more than 6 to 8 grams in a day, can cause proteinuria because excessive filtration, GFR, the same mechanism. And if you consume red meat, that is non-vegetarian food, predominantly chicken, mutton, pig, pork, and beef, in such scenario, you will have proteinuria. And we advise them to take any kind of vegetable protein. Vegetable proteins don't tend to have proteinuria unless you have fortified it with excessive salt. Like, for example, eating a bhaji continuously, 10 bhajis, that can cause proteinuria because of excessive salt, not because of the protein.
Right.
So eating animal protein is restricted, whereas eating vegetable protein in the form of dals and is not restricted for proteinuria. Salt restriction, water restriction, very, very essential in such a scenario.
Okay. I think it's a point well taken. Great points. So again, just quickly we'll take a few questions from the audience. If they want to unmute yourself, then ask our guest nephrologist today, Dr. Arun Kumar. Anybody would like to ask a question live, please just raise your hand and we'll allow you to talk. So just quickly take a few minutes. Yes, we have one question. Okay. Dr. Khadija. Okay. Dr. Khadija, you're live. Can you just ask your question?
If the eGFR is low, around 25, can we start statin for this patient for the first time?
Okay. Dr. Arun, statin,
Yes,
can you start with the eGFR of 20s?
5.
you can start, sir. All our
25.
CKD patients are on statins because any patient who has CKD is a high risk for having a vasculogenic issues, that calcification, atherosclerosis, and atherogenesis. So we can start them on statins.
Yes. And would you do some sort of a dose modification for statin?
So generally, we don't advise for dose modification because we need more statins. We generally say we do more dose modification with respect to if you're using atorvastatin, if you're using 20 mg, we bring it down by 50% to 10 mg. But if they are having a stent in place and GFR is low, we don't tend to reduce the statin dose. We give them the full dose because it depends on the case-to-case basis.
Yeah, again, risk versus benefit, I think you would have to take. But again, don't deny, like you said, don't deny the patient a statin wherever indicated, right? So yeah, thank you, Dr. Khadija, for this kind question. I think anybody else who had raised their hand, yeah, anybody else would like to ask live? Okay, so I think we are done with the questions. Dr. Arun Kumar, thank you so much, for being part of this. And thank you for your kind insights on this entire journey of this patient. I think the idea was to really see this from a real life perspective. And thank you all to the audience also for being a part of this event. So thank you so much. And any words from Siddharth or anybody from Zydus who would like to give their recommendations?
Yeah, thank you, sir. Thank you, Dr. Arun, for a very lucid presentation, sir. Indeed, it was a great interaction today. It was very much more of conversations and dialogues exchanging between everyone. So, thank you so much for giving you an hour. And once again, thank you, sir, for arranging this, sir.
And Vishal, any words from you?
Right. Thank you. First of all, thank you so much, Dr. Arun. It was such a great practical knowledge. And I think a lot of concepts got cleared. And it was interesting because it was not just a case discussion, but also a lot of concepts, a lot of definitions that was also running a bit from my end. So it was all getting clear. So it was more like a teaching school. We were in a school, back in school, but it was only more interesting. And to make it more interesting, thank you so much, Dr. Arun, for beautifully taking through this entire presentation. Cannot thank you enough. Thank you so much. And last but not the least, thank you so much, all the attendants, for that very active engagement. Thank you all.
Yeah. So I think that's the best part. We had very good engagement throughout the series so far, Dr. Arun. And I think, thanks to, experts like you that, and thank you for taking your time for answering all the questions patiently. And yeah, thank you so much. So good night, everyone.
Thanks a lot to you for putting everything into perspective and making it sure that all the points are taught, and you have made a structure. It's so nice that there is no other way for us to escape. So you'll have to discuss everything. So
yes,
you have made it so mandatory for us to discuss every point, and you do give knowledge. I have had a wonderful, I've been an audience in the last and the before conversation. So I'm very, very happy to be associated, and you interviewing me for the questions. I was a little apprehensive because I was afraid you may ask all the trials. So I don't want the trials.
Oh, okay. Yes.
Thanks a lot, sir.
Thank you. Thank you, Dr. Arun. Thank you so much. And thank you so much. And thank you to the audience, and good night, everyone. Good night.
Good night. Thank you.